I'm really excited to talk to you today about EVALI and vaping. I got interested in this as we started to see more cases come into both our clinic and the hospital. Let's see, how do I move it forward? There we go. I don't have any conflicts of interest to disclose. So what I'd like to talk today is about what is EVALI and the statistics that we know so far, the role of vitamin E and THC in the development of EVALI. What does it look like in adolescence? How did we get here? How did we get to adolescents vaping nicotine? What's the difference between what we see in adolescents and adults? And then also just thinking about how does this adults vaping affect children and the passive exposures? Thinking about mental health and substance use, that comorbidities that go along with adolescents who are vaping, and then what's happened to EVALI during the COVID era. So what does EVALI stand for? It's a mouthful. Electronic cigarette or vaping product use associated lung injury, EVALI. It's defined as the onset of pulmonary infiltrates on chest x-ray or chest CT within 90 days, so 3 months of vaping without an alternative cause after workup. The biggest cause to be ruled out would be infection. Other causes to think about would be cardiac, rheumatologic, and in adults, not so much in pediatrics, but neoplastic processes. They have also defined probable EVALI. So this is in a patient who no infection workup was done, but the clinical course and imaging looks like EVALI, or that an infection workup was done, but the pathogen that was found was not thought to be related to the symptoms. So it's basically a diagnosis of exclusion. Another mouthful here, electronic nicotine delivery systems, ENDS. So that's kind of the global term for e-cigarettes, vaping, all those different products have been around since 2007, but the first case of EVALI wasn't reported until 2013. So what changed in that time period? Well, we'll talk more about the role of vitamin E acetate and then also THC's role in being linked to EVALI cases, with keeping in mind that there's still cases of EVALI that have only nicotine exposure and don't have any evidence of vitamin E or THC. So EVALI was declared a public health emergency by the CDC in 2019. They started collecting data in August of 2019. As of February 18th, 2020, there were over 2,800 EVALI hospitalizations. This includes adults and adolescents. 68 confirmed deaths in all 50 states and territories. 78% of the patients were under the age of 35, so really hitting a younger population. There was a male predominance, and the median age of patients with EVALI is 24 years old. Almost half of the patients required intensive care treatment for respiratory failure. So this is looking at the ER visits and hospitalizations related to EVALI, the EVALI epidemic. On the left there, you'll see the ER admissions, and this excludes injuries unrelated to EVALI, like device explosions, accidental ingestion of the e-liquid cartridges. But it does include potentially related syndromes like acute intoxication of nicotine or THC. So you see the peak there in September 2019, with then on the right, the hospitalizations related to EVALI between February 2019 and January 2020. And as we all know, what happened in 2020, suddenly COVID appeared. And so we'll talk about whether that is playing a role in this decrease that we see here.
Was that for Davina?
Someone please mute.
I'm not sure if you're able to mute.
Oh, there.
Thank you.
I was going to go ahead with the funky background music. So, oops, I got to get out of this to make it move forward. So what are markers of EVALI? There's no one specific test that diagnoses it. What we do see is a leukocytosis, so evidence of inflammation with a neutrophilic predominance, elevated inflammatory markers such as ESR and CRP. In BAL fluid, so bronchial alveolar lavage fluid, they found increased lipid-laden macrophages, but this is non-specific and can be seen in other pulmonary pathology. Universally, it seems to be steroid responsive, which is helpful. There we go. So what are the symptoms of EVALI? Systemic, if everyone could mute, that would be great. Systemic, we see fatigue, fever, weight loss. From a pulmonary side, we can see the whole range of cough, wheeze, chest pain, shortness of breath, dyspnea on exertion. And also it's important to remember that there is a GI component. So even though lung injury is in the title, we do see abdominal pain, nausea, vomiting, and diarrhea as symptoms of EVALI. And we'll talk more about that. So this is a proposed schematic of all the different ways that vaping affects the lungs. So at the top, you see the cellular effects, so that lipid-laden macrophages, so those, if you remember back to med school, are eating up the oil that is inhaled and trying to get rid of it. There's altered functionality of the neutrophils, so they're not able to work as well as they should. There's airway effects, so a normal airway is there, and then you see kind of similar to asthma, so bronchospasm, cough, and increased mucus production. And we do see higher rates of asthma in EVALI, increased asthma exacerbations in people who are vaping and have asthma, and more symptoms of chronic bronchitis due to that increased mucus production that occurs. And then the parenchymal effects, there's a whole myriad of interstitial lung disease that has been associated with vaping. And then, of course, EVALI that we're talking about today, where we see this acute fibrinous pneumonitis, we see alveolar damage, and organizing pneumonias. And then the last part to think about is we really don't know yet the chronic effects of vaping. What is this going to look like in 20 years when all these young people who've been vaping are older? Is, are we going to have more COPD? What does that look like? So I mentioned asthma in EVALI, and interestingly, asthma is reported in 30% of the cases of EVALI. Just to remind you that in the general population, asthma only makes up 8 to 10% of people. So asthma is more common in adolescents with EVALI, with 43.6% versus 28.3% in adults. There's increased asthma exacerbations, as I said, and they seem to have, patients with asthma who get EVALI seem to have increased risk for more severe course with intubation and even VV ECMO being required. They also have an increased risk of fatality in patients with asthma versus patients who don't have asthma, so 23% versus 8%. I did find this advertisement from a long time ago with advertising asthma cigarettes for temporary relief of asthma, but hopefully nobody is prescribing vaping as a treatment for asthma. Although we have joked that if we could put inhaled corticosteroids into the vaping pens, we might actually get better compliance for our asthma patients. So this is typical imaging that we see. So usually the chest x-ray is going to show bilateral pulmonary opacities, and then further imaging with chest CT shows bilateral ground glass opacities with a basilar predominance, and you may see subpleural or lobular sparing, but looks pretty terrible. So the other lung pathologies caused by vaping, which we saw in that schematic, there's a whole list of them, right? But what makes EVALI different? So as the EVALI epidemic spiked in 2019, people quickly jumped to try to figure out the common denominator. This article was published in February 2020 and found, looking at vitamin E acetate in BAL fluid of patients who had EVALI. So they looked at 51 patients with EVALI from 16 different states and compared them to almost 100 healthy participants who were part of a different study. They found that vitamin E or VEA was found in 48 out of the 51 patients. So 94% of the patients with EVALI had vitamin E acetate in their BAL fluid, but none of the healthy controls had that. Similarly, they found almost the same number, 47 out of 50 had detectable THC or marijuana in their BAL fluid, or metabolites of THC, or the subject had reported vaping THC products in the 90 days before the onset of illness. And then they also looked at nicotine and its metabolites, and they were detected in 30 out of 47 of the cases. So nicotine is clearly part of the issue, but is it vitamin E that's in all of these products? That's still to be determined. So vitamin E acetate is added to illicit black market vaping products. It's a way to dilute the THC. It's thought to help with its appearance, taste, and the cost of the product. And so, why does this cause a problem? Well, one theory is that because the vaping products heat up the particles into such small particles, they actually reach the alveoli, and that this disrupts the surface tension by interacting with surfactant and then causing alveolar damage. Another theory is that high heat in the vaping products is a catalyst for other toxins to be made. And one of the byproducts of vitamin E at high heat is something called ketene gas. And we know that ketene gas in low concentrations can cause severe lung damage. In high concentrations, it can even cause death. But again, there's still multiple theories on why this is causing EVALI. Oops. So with this in mind, a different group looked at a mouse model and then also a human cell model to look at how aerosolized vitamin E acetate affects the cells in the airways. And so on the left there, they basically exposed mice to aerosolized vitamin E for 6 days and then for 15 days. And this is the control. And what you see is this is the blood vessel in the airway. The purple dots are the lymphocytes. And so there's an increased lymphocytic predominance, so an increased perivascular inflammation in the lungs of mice exposed to aerosolized vitamin E. And this is dose dependent. So the longer you're exposed, the more inflammation occurs. Similarly, they looked at whether the vitamin E was being absorbed into the cells. So here's the control. And then here is the mice cells that are exposed to aerosolized vitamin E. And the red dots are the red oil stain or the vitamin E. And what it shows here is that it actually is taken up into the cytoplasm of cells in the lungs. Oops. So further, they said, well, let's look at how does this affect the human alveolar epithelium. So we've looked in mice, and it's definitely causing an issue there. They put together a cell culture, which is displayed here, and again, exposed it to aerosolized vitamin E. And what they found was the longer that the cells were exposed to vitamin E, the more cell death occurred. So, and then they compared it to a control and then also Juul, which I think most people know is one of the main producers of e-cigarettes. And they found that there was increased monocyte and neutrophilic chemokine production, as well as cell death in those exposed to the VEA, even more than the Juul. This is not to say that Juul is safe, but does highlight that vitamin E is maybe causing more of the EVALI issues than just a straight Juul product. And finally, as still part of that study, they looked at the alveolar cells and spun them down, and again found increased vitamin E the longer that the cells were exposed, and also started to see that there were breakdown products of vitamin E the longer that the cells were exposed to vitamin E. Additionally, I don't have the diagram for this, but they also found that there was increased pulmonary edema the longer that the cells were exposed to vitamin E. So clearly, vitamin E is toxic to the lung cells, but there's more to the story. So EVALI in pediatrics, that's why we're all here today. What's been reported is over 1,300 cases in young adults by January 2020. The symptoms are similar to what we see in adults. As I said before, cough, dyspnea, we do see hypoxemia. Interestingly, the GI symptoms seem to be more common in adolescents than adults, so very important to think about when patients are coming in with GI symptoms. We do see headache as well, and then, of course, the elevated inflammatory markers and changes in chest CT. So this is a cross-sectional study of CDC data. The N was over 2,000 subjects with EVALI. And what they found was a disproportionate amount of adolescents and young adults hospitalized with EVALI compared to the total population. So 360 hospitalized adolescents, so in the 13 to 17-year-old range, and 859 of the patients hospitalized were in the young adult range. They also found that adolescents reported 62% were using nicotine, almost 82% were using THC, and 50% reported using both. So this is some scary data, especially in light of looking at current tobacco use among our high school students. So between 2011 and 2019, we were actually making progress in decreasing tobacco use, but then the red line there, as you can see, dramatically increased tobacco use of e-cigarettes. So the red line is e-cigarettes, and then all the others are cigars, cigarettes, smokeless tobacco, hookah, and pipe. All were coming down nicely, and then e-cigarettes jumped the tobacco use again. So I just wanted to incorporate two cases that we've seen at UNC. One is a 15-year-old young woman who presented to the ED with shortness of breath, dyspnea on exertion, cough. When she got to the ED, her SATs were 85% on room air and improved with 2 to 3 liters of supplemental oxygen. All of her inflammatory markers were extremely elevated. She was afebrile. Her respiratory viral panel was negative. The chest CT showed diffuse ground glass opacities. Upon further questioning, she revealed that she had increased use of vaping products over the past several months. She felt like it calmed her underlying anxiety better than prescription medications she had tried. So she had dramatically increased how often she was vaping. She was started on corticosteroids, and her symptoms and oxygen requirement improved in less than 24 hours. The second case, which one of our residents actually wrote up, was a 13-year-old young man who presented with a 1-week history of abdominal pain, nausea, and vomiting. He'd had a 5-kilo weight loss in the month leading up to the admission. He had been admitted 3 months earlier to a different hospital with the same symptoms, but also had headache at that time. He had significantly elevated inflammatory markers. His abdominal CT, this is at the outside hospital 3 months earlier, showed dilated loops of bowel and left lower lobe atelectasis, so caught the bottom part of the lungs. He was discharged on ciprofloxacin. It's not exactly clear why that was given. And then he was scheduled for outpatient follow-up with GI, and who planned to do an EGD the week of his second admission. So he came to UNC and he was admitted for this abdominal pain. And while he was inpatient, he desaturated to 75% on room air. He had severe chest pain on hospital day 2, which led to a chest CT and the diagnosis of EVALI. this isn't their imaging, but again, is very similar to what we saw in their chest CTs and is common in EVALI cases. So again, the ground glass opacities, septal thickening. This second case, there was a pulmonology consult on that second day of hospitalization when he desatted and the chest CT was was abnormal. And our fellow elicited a 12-month history of Juul use, particularly the mint flavored cartridges. And this adolescent's urine analysis was positive for THC. He also was started on corticosteroids and easily weaned to room air. Lucky for him, his follow-up chest CT in 4 to 6 weeks was almost completely resolved. So all of this ground glass opacities had returned to normal. So what have we learned so far at UNC? If you don't ask, you won't know. At least 2 of the cases that we've seen had admission at outside hospitals prior to the diagnosis. Initially, when e-cigarettes were gaining popularity, parents and adolescents were very open about vaping in clinic. They viewed it as safe. Parents viewed this as a good alternative to tobacco, cigarettes, or other drugs. We had several cases where parents were actually purchasing the vaping products for the adolescent. Subsequently, with all the press, I find that they become more resistant to reveal that, but overall, pretty open compared to other drug use. Additionally, what we found, like in our first case, is that patients were at least reportedly treating underlying anxiety or depression with the vaping. And what we've also learned is it's really important to quantify what they're using and how frequently they're using. As we increased our number of cases and we went back to look at the original ones, we weren't asking how many cartridges they were using a day, what product they were using, whether it's flavored or not. And so that really makes it difficult then to differentiate what's causing the symptoms. So really, you ensure you understand what product they're using. Are they getting it from other people, or are they buying it through regular channels? All of our cases have been treated so far with glucocorticoids. So we can't say for sure whether the symptoms would have resolved by just removing the vaping exposure. There are case reports of improvement without steroids in patients who are not hypoxemic. So I think, if you've been admitted to the hospital and are needing oxygen, most people are going to prescribe steroids, since we know that this process is very steroid responsive. But it is interesting to think about, if you just remove the insult, would that be enough? So who are these products for? You see all these bright colors and young subjects looking like they're having a great time. If you ask the e-cigarette marketers, they'll say that, oh, it's supposed to be used as a cessation tool for adults, so as a way to stop smoking cigarettes. But when you look at these ads, you don't really see that as the message. And the similarities to early tobacco ads are frightening. And so it's really turned into more of a gateway product to introduce teens to tobacco and nicotine, rather than to stop them from smoking or vaping. So youth are exposed to e-cigarette advertisements from multiple sources. So even with controlling advertising, they're still seeing it. In this study, 14 million youth are exposed in retail stores. 10.5 million are exposed through the internet. Close to 10 million are exposed through TVs or movies where they see vaping. And then 8 million are exposed through magazines and newspaper ads. And then when you look at all of that, how many different sources our middle school and high school students are exposed to, you see that quite a large number are exposed to all 4 sources. So they're getting inundated with these colorful, happy vaping ads. And again, it's being advertised as a safe alternative to tobacco cigarettes. But I don't know that tobacco cigarettes should be our gold standard for what is safe. And, you know, as I said before, the campaigns mimic early tobacco cigarette campaigns. And so despite the limitations on advertising that has been imposed, social media still continues to promote vaping on Instagram and TikTok and Facebook, and the use of hashtags for Juul or vaping products are very high. So even with restrictions on advertisement, they're still seeing it in their social media feeds. This bottom graph shows that e-cigarette use among youth is rising as the advertising grows. So the green bars are the dollars spent on e-cigarette advertising, and the red line is the past 30-day e-cigarette use among youth. So what do adolescents choose? Studies in 2013 and 2014 showed youth start with the flavored variety. Flavors are the main reason they start using e-cigarettes. In 2020, this trend continues with 83% of youth who use e-cigarettes use the flavored varieties. They like the fruity flavors most, then mint, but then I think probably most people are aware now there's candy, dessert, vanilla wafer, unicorn puke, I think is even one. And so a third of youth are picking those sweeter types. None of these really seem like they would appeal to most adults. Again, adolescents are first-time users, and they preferentially use the refillable cartridges. So that means that anything really could be added to them. So they're easily tampered with, and oftentimes they're getting them from friends or not through proper channels. And so it's really hard to know what's actually in that cartridge that they're vaping. So why do these choices matter? Well, the lack of regulation on e-liquid formulation. So even with some of the regulations, there's still not very much oversight in what is put in those e-liquid cartridges. And again, these cartridges are easily modifiable. So you can add THC to products that were bought through the proper channels. And adolescents don't actually know what they're inhaling. And then this lack of regulation and lack of standard ingredients makes it really hard to do research and find commonalities for why we're seeing EVALI, why we're seeing these changes, and try to figure out what is going on with the pathophysiology. Oftentimes when we've asked patients, you know, do you still have the cartridge that you used? You know, it's long gone. So you're not able to look at what they specifically inhaled. There are lots of counterfeit cartridges, again, so adolescents don't actually know what they're inhaling. And so all of this really puts adolescents at risk for unknown exposures and risk for lung damage. This is a study from Ilona Jaspers at UNC looking at the components of that we do know of vaping products, so propylene glycol and vegetable glycerin. And so really thinking about what do we know about acute exposures versus chronic exposures. So you can see there, we know that those components cause increased cough, dry throat, chest tightness, cause that increased mucus secretions. It does cause minimal effect on lung function and exhaled NO, which is an inflammatory marker. But then chronic exposures, we have workplace exposure associations that we can pull from, where you do see over a long period of time reduction in FEV1 and FVC. But we really have no data on chronic inhalation exposures from e-cigarettes. The flavoring agents, it really depends on which flavoring they're using. But again, there's very little data to know what the acute exposure results in or the chronic exposure. We do know that popcorn lung can cause bronchiolitis obliterans. So we do know some about the flavorings and chronic exposure. But still, all of this is ripe for research. And again, not understanding what we're looking at in 20 years after adolescents have been smoking this for a while. And then nicotine we know more about thanks to tobacco, cigarettes. But again, we don't know how nicotine plays a role with these other components and the high heat that these components reach in that vaping product and what breakdown components are actually reaching the alveoli. So we've talked about adolescents, but this is also an issue for children, right? Because if parents are using vaping and they think it's safe, and so we've told them over and over they need to go outside to smoke cigarettes and avoid exposure, well, now they think they're being safe using vaping products. So very important for us to think about this when we're talking to parents and environmental exposures for our patients. So this was just one study looking at passive and active exposures to vaping fumes. They looked at 5 vaping shops and tried to assess secondhand and third-hand smoke. They measured nicotine, tobacco-specific nitrosamines, and measured it in the air, but then also on surfaces, which I thought was pretty cool. So they put glass, paper, clothing, rubber, and a fur ball were hung in the shop for 14 days to assess third-hand exposure. They found significant secondhand exposure as we would expect, but they also found higher third-hand exposure than is what compared to what's induced by cigarette smoke exposure. So getting in fabric and on surfaces, these was higher from the vaping than what we've seen with cigarette smoking. And so we already know that nicotine can be deposited and absorbed in children's clothes and toys. And now we need to think about vaping as well. And clearly we need more study to understand this and to be better able to counsel our families. But the bottom line is it's important to ask. So not just asking about tobacco smoke exposure, but asking if people are vaping and if they're vaping in the home. And another study looking at passive exposures, again, I found another cool study, very small N of only 17 healthy volunteers, but they estimated bystanders exposure in different scenarios. And so they looked at a non-ventilated car. So thinking about a parent vaping in a car with the windows up, a ventilated office. And they found that, oops, somebody could mute.
Hey, can I get a vanilla latte to go, please?
Could you please mute?
Can someone please mute?
I'll take a vanilla latte. So the e-cigarette use has effects on the healthy bystanders and things that affected their exposure. It all makes sense, right? So the rate of ventilation in the room, having the windows up versus down, the size of the room that the vaping is occurring in. So a smaller room where they're vaping and poor ventilation has increased exposure for the healthy subjects. And then obviously how much they're vaping and what products they're using. So there's still a lot that we need to know. And I thought this cartoon was funny. Mind if I sit here? I'm addicted to secondhand smoke. So clearly we have a lot to do to protect not only our adolescents, but our children. So just to circle back to our 2 cases, we sent them home on 10-day total course of oral corticosteroids. We offered vaping cessation counseling. One of the patients had significant nicotine intake and was offered nicotine replacement. Both of them were treated for underlying mental health issues. At that 4 to 6 week follow-up, we saw resolution of the inflammatory markers and the imaging studies. They both had normal lung function testing, and neither had returned to vaping. I can't say that all of our cases have been that successful. We've had one patient who's a repeated offender with vaping and EVALI, but unfortunately his family also, everyone in the family vapes. But the good news is in the short term, we are able to recover the lung function and imaging. And so if we can intervene now, there's hope. There's hope for the future. So this idea of mental health, I wanted to get back to because both of our, well, a lot of our cases and both of the cases I highlighted had depression and anxiety. So this has been documented that mental health and behavioral issues were almost 4 times higher in teens with EVALI than in adults. There is some question whether this is exacerbated by nicotine toxicity or whether like they're getting withdrawal from nicotine and then that's making anxiety and depression worse. And so then they're vaping more. Again, more basically with everything with vaping, more study is needed. There's increased ADD and conduct disorders in adolescents who vape, increased use of alcohol and binge drinking. 93% of the adolescents using ENDS products or e-cigarettes reported using other substances. Alcohol and THC were the highest of the other substances used. And there's a higher risk of fatality from EVALI in adolescents who had mental health and behavior issues. So really important to think about that and getting help for our teen depression and anxiety. So where do we go from here? These are just a couple smatterings of cartoons. You know, we've got teens thinking it's fake news. There's the candy flavored, all the different bubblegum flavors, and you know, marketers saying, no, we're not trying to to sell this to adolescents. And then teens and parents trying to sell that this is healthier. But you know, broccoli's healthy too, and a lot of teens won't go near that. So what can we do? I think advocacy and regulations are really important. The FDA's Youth Tobacco Prevention Plan, part of it has a comprehensive plan for tobacco and nicotine regulation. Education programs for teens, schools, and parents about vaping and the risks of vaping, continued efforts to limit the access and exposure to vaping products, continued limiting of marketing and flavoring. I think if we're really saying this is a cessation tool, I don't think you need 30 different flavors to help adults stop smoking. There's even some debate about maintaining the ability for adults to use it as a cessation tool. If it is causing damage, is this really what we should be using? But there are also strong advocates for using it as a way to stop smoking for adults and that have been successful. So I think that's still up for debate, but worth thinking about. And really just increasing healthcare provider awareness about the vaping epidemic and EVALI symptoms, and really having open conversations with patients and parents about this, you know, about vaping and what can happen. So what happened to EVALI? You saw it dropped off in 2020, and so did it go away during the COVID era? Again, it's still a diagnosis of exclusion, so you should have a high level of suspicion for it. The symptoms can overlap with COVID. And then adolescents who are vaping have been shown to be at increased risk for COVID infection. So a survey looking at over 4,000 13 to 24-year-olds found that COVID diagnosis was 5 times more likely in adolescents who vaped, 7 times more likely in adolescents who both vaped and smoked cigarettes, and almost 7 times more likely in recent users. So if they had been vaping in the last 30 days, that put them at risk for COVID infection. And so as I kind of mentioned, you know, is there less EVALI being identified during COVID? So is it that we've reduced the vitamin E in these products, and so we've gotten rid of EVALI? Is it being misdiagnosed as COVID? Is there less vaping overall? I've seen data both ways, that because kids were home with their parents, they couldn't vape as readily versus the stress of the pandemic and the increased mental health issues associated with the pandemic causing an increase in vaping use. So the CDC actually discontinued collecting case reports in February 2020, so we don't really have a good reporting system anymore to track EVALI. They encourage state health departments to continue to collect data. But the last time the CDC page on EVALI was updated was February 2020. So really there's a paucity of data. Now, obviously the COVID pandemic hit and was a much more pressing public health epidemic. And so research expertise, resources, and funding were all focused, rightly so, to COVID-19. And the number of EVALI cases has dropped off. And is it because we're not reporting, or is it just less cases overall? And interestingly, there are currently no active funding opportunities devoted to EVALI. And during the pandemic, it's not the most critical thing for us to be looking at, but I don't think we should forget about EVALI and its effects on our adolescents and children. So, the CDC had recommended to make vitamin E not part of ENDS products. So the big manufacturers have removed that. We still don't know about the off-label products that teens are using. And there's still cases of EVALI even with that reduction. So there's still other factors, and whether it's these breakdown products that lead to EVALI, not just the vitamin E and THC. So future directions, I think part of the reason I'd want us not to forget it is this is a preventable disease. So if we, a lot of us went into pediatrics because we have that opportunity to help prevent future disease. And so really taking it on to make sure that we're educating our families about this and hopefully preventing further issues in the future. And again, as you heard me say multiple times through the talk, there's still a lot we don't know about EVALI and vaping. And currently there's a lack of research funding and studies during the COVID epidemic. I'm part of an ATS working group that's looking at, research areas that need to be researched and to push forward with still thinking about these exposures. Again, there's no proven test to diagnose it, no proven treatment. So we're at the mercy of a diagnosis of exclusion. Luckily, steroids seem to work really well. Another concern is increasing legalization of THC across the country. So will we see more issues with EVALI again as there's more accessibility to legal THC? And overall, even with the regulations that have been put in place, ENDS continue to be relatively unregulated. And so it really continues to be an epidemic for our teens, and we don't know the chronic effects of this exposure. So in conclusion, EVALI does occur in adolescents. They may be at higher risk due to the flavoring and the refillable cartridges, so that they don't know what's being put in what they're inhaling. We need to consider passive exposure for younger children as well, not just the adolescents. Again, it's a diagnosis of exclusion, but critical to have a high level of suspicion, and especially in the GI symptoms, as they're found more frequently in adolescents. And as our cases at UNC showed, a lot of these teenagers had showed up at other EDs and hospitals and sent home. And so just having that alarm go off in your head when they come in with systemic complaints. And be vigilant about asking. I think we've all become really good at tobacco and other drugs and alcohol, but including vaping in that list of things that you're asking in a teen history, but also in a parental environmental history. Vaping is associated with other comorbidities like mental health, COVID-19, and asthma. And again, we need more research to better define, diagnose, and treat EVALI. And so my last slide before questions is a shameless plug. I am the medical director of the UNC Children's Specialty Services at Raleigh. So hopefully you all know we're there. We're right across the street from Rex. Our outpatient specialty clinics are open Monday through Friday. We have over 26 different teams and divisions seeing patients there. We have imaging and labs Monday through Friday. And we also have this beautiful pediatric infusion center that's down here. And we are providing pediatric COVID monoclonal antibody infusions to patients who qualify. And then we have a pediatric urgent care that's open 7 days a week, including the holidays. And weekdays we're open 4 p.m. to midnight, and then Saturday and Sunday 12 p.m. to 12 a.m. So I'm happy to take any questions. Thank you for having me today.
Celia, this is Irene Chow from Triangle Pediatrics.
Hi.
Thank you for this talk, very informative, and I knew nothing about it, so it's very helpful. I want to ask you, so because I'm so ignorant, how is the THC exposure different through vaping and through smoking just a joint of pot?
Yeah,
That
so
would,
it's the heat, and so it's able to basically vaporize it into smaller particle size, so it can reach deeper. It can reach the alveoli in the lungs, so it can cause more damage than just a regular joint.
okay. And also the possibility of other things they add to these whatever vaping instruments, I mean liquids, to make it palatable.
Oh, I lost you. I think you were saying, and it is, yeah. So they were adding vitamin E as a way to kind of dilute it, to be more cost effective for the people selling it, and then for taste and appearance. But I couldn't hear you, so I don't know if you had other questions.
Oh no, that's it. I'm just trying to be able to articulate to the teenage they say, oh, I'll try. But I just want to make more impactful statements to them. That's all. Thank you.
Yes, you're welcome.
Hey, Ceila, this is Alex Ahern with Rex Peds. I'm curious, how would you approach working one of these patients up, given that it is a diagnosis of exclusion? Obviously, clinical suspicion is going to be really important. In both of the examples that you gave, they ended up having CT findings that helped to really circle around a final diagnosis of EVALI, but it's kind of curious about, when you're working somebody up, how do you approach it? When do you decide you've done enough to rule out other etiologies?
Yes, they both had findings on chest x-ray too. I didn't show that, but that's what pushed them to then chest CT to further define it. I think that GI patient, they were so focused on the abdomen and just kind of discounted that left lower lobe atelectasis that they had seen in the original abdominal CT. I remember from PEDS boards, that's always that classic question, right? Somebody comes in with abdominal pain and they actually have a lower lobe pneumonia. And so I think kind of the same thing should be going through our head. And then really it's been the history. So in these cases, nobody had really asked the teen about the history. And I think teens and parents are connecting the dots better now, but these parents were shocked that this is what was causing their kid to be so sick and to have the weight loss and fever. They were sure there was something else going on. So I think that making sure that we're asking that clinical history, and then the chest x-ray did show findings, but then the chest CT was further definitive. So you probably could get away with a chest x-ray, but I think there's still so much we don't understand that everyone jumps to getting that further definition.
Did you say they all have shortness of breath and some have abdominal pain?
It's a range of pulmonary symptoms. So the case that we wrote up about the abdominal, he wasn't describing shortness of breath or dyspnea. He was really just focusing on the abdominal issues. So it can be, it's more likely that it's GI and pulmonary and the systemic symptoms, but it can be just GI symptoms. And so that's why we wrote up that case, because it was deceiving. But then we see the range of just plain chest pain without wheeze or cough. A lot of them have cough, shortness of breath, exercise intolerance.
Celia, this is Melanie Walker from Pediatric Partners. Sorry about the coffee order, but
I want one. Can I have it?
But I just, Alex and Irene actually covered my question. I just wanted to thank you so much for directing that Raleigh center. Our patients have just loved it. The urgent care has been really convenient and always really, really great care. And having all those specialties right here is such a coup for all of us practicing in Raleigh. So thank you so much for all that hard work.
Oh, thank you. That's really nice to hear. It has, we opened up in December and then COVID hit, so it's been a challenge to say the least.
May I ask a question about that specialty center?
Yes.
Because we are finding it challenging to get serum bilirubin in babies who are discharged from Rex and UNC over the weekend. What were your lab? Can we order serum total Billy from there on the weekends? And what are the hours available for newborn bilirubins? Because the hospital, we couldn't get it done in the hospital, or they asked us to send them to urgent care for evaluation or something like that.
Yeah, Emily and Alex might be better, but they definitely are coming on Saturdays and Sundays to get bilirubin checks to the urgent care. I don't know if either of you have experience with that.
Yeah, we routinely have sent newborns who need a follow-up Billy who aren't able to get one through their pediatrician to the urgent care. Their hours on the weekend are noon to midnight. The families can schedule appointments online for the urgent care, and often for the newborns, I'll show them the website and then say, why don't you take the first appointment of the day? But I mean, they can obviously go whenever, but we've had pretty good success of being able to get the labs drawn, and then there's someone there that will follow up on it, or you can also communicate, or it'll come up in Epic, whenever the results come back. But I know recently we've had a little more difficulty with the Rex lab. I've had a couple instances where they've been just so busy that there have been newborns who haven't been able to get their labs in a timely manner. And then there were some equipment issues the other day. So I do think the urgent care has been a good option.
So we cannot just order labs through like UNC Epic. Can we just like send an order to go to the lab and get bilirubin drawn?
Not on Saturday and Sunday, I don't think. I think you actually have to have an urgent care appointment. Is that right, Emily?
Yeah, I've never done that. I've always done it through having an appointment. Sometimes what they'll do is it can be a nurse visit. So the nurse will just kind of check in and run it by the doc. So the families aren't getting charged for an urgent care visit, but they'll just get charged for the lab.
Okay.
Yes, that's what they're doing. So nurse visit, because during the week you can order labs and they can come in, and you can order imaging and they can come in, but on Saturday and Sunday, there's just not the staffing for that. But you're right, Emily, it's a nurse visit.
Okay, so who will schedule a nurse visit? I will. I ask them to get a nurse visit, or they schedule a nurse visit.
Either you or the family. Either way.
And it's through the same appointment site?
It should be.
Okay.
Mm-hmm.
All right. Thank you.
Absolutely.
So I had one more quick question for you. We're frequently counseling families in the newborn period. When you were doing your literature review for this, did you come across any data on secondhand exposure from vaping and SIDS risk? I feel like that comes up frequently with patients who have switched to vaping because they are under the impression that it's safer.
Yeah.
And I counsel them on it, but I don't know the data very well.
Yeah, I did not see that data, but certainly we know tobacco smoke, right, is a risk factor. So I would assume, but again, it's an interesting question. So I'll have to look that up. I would guess that there's probably not much data on it. So it would be good to look at.
I have another data question. This is Arshia Ahuja. I'm one of the pediatric hospitalists at Rex. I was just curious about whether patients with EVALI, whether they're at increased risk for secondary bacterial pneumonia, and if so, whether and what that incidence is, and also whether the etiology is different than our general population.
Yeah, so there's increased mucus secretion. So you do see chronic bronchitis, and I don't know the incidence of pneumonia with it, but I would assume that it's the same as, someone with asthma or anyone else who has increased mucus production. But that's a great question. Certainly, there's documented chronic bronchitis, but I don't know the numbers of pneumonia.
One question I had was, obviously there's a lot of variability in the different products and then the unregulated products, but do we know if now after the vitamin E has been removed, if we're still seeing EVALI from the standard products or mostly just from the unregulated products or the modified products?
Yeah, I don't think that that's been delineated. Like we're still seeing it. And so I think the dramatic reduction I would guess, is from the manufacturers eliminating that. But we're also seeing it in subjects who just have nicotine exposure. So there's probably still something else about the inhalation that causes that damage, and not just the vitamin E and THC. But I would bet that since we saw such a dramatic drop, I think it's probably related to the manufactured products, not the off-label, what kids are sticking in their cartridges, unfortunately.
Very small logistical question.
Yeah.
You mentioned asking how quickly they're going through cartridges. I have no context for what is heavy use or mild use or whatnot from a cartridge standpoint, because all of my training with respect to smoking is
Yeah.
per day. Do you have a sense of what is on the heavier side or lighter side?
Yeah, and that's the scary thing. So some of the products I've seen having as much nicotine in them as a pack of cigarettes. And so the difference with vaping and like smoking a cigarette, there's like an end to the cigarette, right? Like what you'll see is the adolescents just taking hits all the time, kind of all day long. I think they've reduced the nicotine in products because of that, but it's still a significant amount. So I saw one cartridge having a full pack. And so if they're going through, you think about a pack a day smoker, right? And we have kids that are just like had it next to their bed and they're just taking hits off it all the time. And there's just this constant exposure, as opposed to a cigarette where there's a clear end to what you're smoking, or a joint.
The other piece of that too is that with a cigarette, you waste some of it, right? You're sitting there talking and some of it's burning down.
Yeah.
Whereas with the cartridges, there's no waste. So every time they take a hit, they're getting the full volume of it. So one Juul, I don't know about the other brands, but with, like Ceila said, with the Juul pods, those are the equivalent nicotine wise of a pack of cigarettes. But to me, it's more because of the lack of waste.
And the way that it's heated up, it goes deeper into the lungs, so can do more damage. Well, thank you for having me, and feel free to reach out to me if there's anything we can do to help at the Raleigh location or asthma. But I appreciate all of you attending.
Great. Thank you, Dr.
Thank you so
Loughlin. It's
much.
a pleasure. This is great.
You're welcome. Have a good day.
Bye.